This brings us to the next and last talk of André Denault and Mathias Jacquet-Lagrèze. André Denault is, as Xavier Monet, one of the most prolific researchers in cardiovascular anesthesia and intensive care medicine. He's really a true expert in right ventricular function, right ventricular afterload, and he has already given many talks for EACTAIC, either on face-to-face meetings or also online. You might know that he works as a cardiac anesthetist in the Montreal Heart Institute in Canada. And today he will have a talk on the reliability of radial artery pressure monitoring during cardiac surgery. André will have his talk together with Dr. Mathias Jacquet-Lagrèze, who was a fellow in Montreal between 2017 and 2018 and now works in Lyon in France. We are looking forward to your presentation.
Hello, my name is André Denault. I'm a professor of anesthesia at the University of Montreal. Thanks for inviting me, but also Dr. Mathias Jacquet-Lagrèze to talk to you for this EACTA Fellowship Seminar on the reliability of radial artery pressure. I work at the Montreal Heart Institute as a cardiac anesthesiologist. And those are my disclosures, but none of them are relevant to this talk. I'm also supported by the Richard Kaufman Fund in Anesthesia and Critical Care. Dr. Jacquet-Lagrèze disclosures are shown here, and none are relevant to this talk. This presentation is partly based on this editorial written in the Canadian Journal of Anesthesia in 2022. This is a 78-year-old man undergoing aortic valve replacement. In red, the femoral artery pressure. In pink, the radial artery pressure. Note the brain and somatic saturation. After cardiopulmonary bypass, the saturation remained normal, but there is a significant gradient between the femoral and the radial artery pressure. 81-year-old man who has a radio operation for the aorta plus an aortic valve surgery. There are two radial, right and the left, and the femoral artery are shown here after cardiopulmonary bypass. Note again the significant gradient between both radial arteries and the femoral artery. So the question is, do you really trust a radial artery pressure in cardiac surgery? So this is a much more serious problem than it may look like. So this is my plan for the presentation. We'll go over the literature. We'll discuss about our experience at the Montreal Heart Institute. We'll see how we can suspect or diagnose it. What are the clinical implications before concluding. In 1985, Stern reported for the first time a study that included 18 cardiac surgical patients where the radial and the aortic pressure were noted before and after cardiopulmonary bypass. In 13 out of 18 patients, 72% of the patient, a significant gradient of 12 to 32 millimeter of mercury was present. The gradient was attributed to vascular resistance of the forearm. Other reports of this phenomenon were published in 1987 from Israel, 1989 from USA, 1994 from Belgium, and again in 2013 from Florida, just to name a few. In 2009, I published with my colleague Dr. Alain Deschamps this article showing a patient after mitral valve surgery. Those are the femoral and radial artery pressure. Note the systolic 46 millimeter mercury pressure gradient. Our conclusion was that early recognition of this abnormal extensive aortic to radial pressure gradient is the first and most important step in excluding intraoperative hemodynamic instability as a cause of persistent hypotension in cardiac surgery.